So I will be talking, as you said, about atrial fibrillation and how it influences right atrial pressure estimation by handheld ultrasound assessment with the vena cava. I have no disclosures to report. So ultrasound has become an integral part of our practice of cardiology, and the advent of handheld ultrasound has led to increasing portability and accessibility to this technology and facilitated novel applications and point-of-care diagnostics. One of the most directly relevant applications of this technology to cardiology is in the assessment of the patient's volume status, particularly in a patient with heart failure, where assessment of the inferior vena cava, or the IVC, as being dilated or non-dilated can give clues to the patient's filling pressures and guide administration of diuretics. Now, guideline recommendations call for estimation of right atrial pressure estimation by two parameters derived from ultrasound measurements of the inferior vena cava: the size as being greater than or less than or equal to 2.1 centimeters, as well as its collapsibility with inspiration as being greater than or less than 50%, with concordance of these parameters being consistent with an elevated or normal filling pressure, and discordance of these parameters being consistent with an intermediate right atrial pressure. These guidelines are based on a number of studies over the last couple of decades, which have correlated measurements from the IVC with invasive measurements of right atrial pressure by catheter. However, there's a lot of heterogeneity in the studies these recommendations are based on, both in the patient population as well as in the methods of IVC measurement. And importantly, only 3 of these studies have actually included patients with atrial fibrillation in their validation cohorts, raising some questions about the validity of this method to assess right atrial pressure in this group of patients. Now, atrial fibrillation may actually directly affect atrial pressure. There's very limited data to support this. However, some animal studies have suggested that atrial pressure acutely rises to a small but statistically significant degree after induction of atrial fibrillation in the lab. And in addition, patients undergoing catheter ablation have been noted to have small but statistically significant increases in atrial pressure directly decreases in atrial pressure directly after ablation of atrial fibrillation. So what we aim to assess in this study was the dynamic changes in IVC parameters, both size and collapsibility, as assessed by handheld ultrasound, according to the presence or absence of atrial fibrillation. And in order to answer this question, we took advantage of a population of patients in which we could measure both of these rhythms in the same patient, namely patients undergoing direct current cardioversion for atrial fibrillation. So what we measured was the IVC size and collapsibility with a handheld ultrasound device, the V-scan, both immediately prior to direct current cardioversion, as well as immediately following cardioversion from atrial fibrillation to sinus rhythm. And again, we measured the maximum IVC size throughout the respiratory cycle, as well as a visual estimate of collapsibility as greater than or less than 50% with passive inspiration. We included all patients undergoing elective cardioversion for both atrial fibrillation and atrial flutter, and importantly excluded any patient who had a history of prior IVC instrumentation or surgery such as caval anastomosis, as well as any patients who received diuretics or IV fluids in between these 2 IVC measurements. Our measurements were obtained as recommended by the guidelines in the supine position using the subcostal view with the IVC visualized in the long axis, and measurement of the IVC being made perpendicular to this long axis, approximately 2 centimeters caudal to the caval atrial junction and caudal to the insertion of the hepatic vein. We also, as I mentioned, measured collapsibility with passive inspiration. Now, this is an ongoing study, and so far we've enrolled 71 patients, the baseline characteristics of whom you can see here. On average, patients aged 66, predominantly male patients. You can see about 37% of patients were on a loop diuretic for a history of heart failure, either reduced ejection fraction or preserved ejection fraction. Most of the patients had atrial fibrillation, 89%. And you can also see that none of these baseline parameters were associated with the IVC size. Now, getting to the most important data here, the maximum IVC dimension, as measured by handheld ultrasound, was significantly larger when in atrial fibrillation compared to when in sinus rhythm post-cardioversion, with a difference of about 0.2 centimeters or about 10%. And in addition, the proportion of patients that showed greater than 50% collapsibility with inspiration was significantly lower when in atrial fibrillation compared to when in sinus rhythm, again in the same patients. Now looking at these data a slightly different way, on the x-axis you can see each individual patient case with the blue dots corresponding to the IVC diameter when the patient was in atrial fibrillation prior to cardioversion, and the red dots representing the IVC dimension when the patient was in sinus rhythm immediately following cardioversion. And you can see that in most patients there was a decrease from atrial fibrillation to sinus rhythm in the IVC size. Now, we correlated the baseline IVC size with the percent or the magnitude drop following conversion to sinus rhythm. And the patients with larger IVC sizes at baseline were the ones that demonstrated a larger drop on average following conversion to sinus rhythm. Now, interestingly, when we applied the guideline recommendations to assess or estimate right atrial pressure non-invasively based on the IVC characteristics, there was a significant difference in how these patients were categorized comparing atrial fibrillation to sinus rhythm. And you can see that patients were much more likely to be categorized as having elevated right atrial pressures when in atrial fibrillation compared to when in sinus rhythm, and much more likely to be categorized as having normal right atrial pressures when in sinus rhythm compared to atrial fibrillation. And again, these are the same patients separated by about 15 minutes. And when we broke it down by individual patient, about 40% of patients decreased their estimated right atrial pressure by one category, in other words, from either estimated highly elevated right atrial pressures to intermediate, or from intermediate right atrial pressures to normal. 7% of patients dropped actually two categories, from an estimated highly elevated right atrial pressure to normal. And overall, almost 50%, just over 50% of patients were actually reclassified following conversion to sinus rhythm. I want to show a couple of case examples. This is one example of a patient who had a dilated IVC measuring 2.62 centimeters when in atrial fibrillation, which decreased significantly to 2.2 centimeters following conversion to sinus rhythm. Or another patient who measured 1.52 centimeters when in atrial fibrillation compared to 1.31 centimeters when in sinus rhythm. Of course, not all patients demonstrated this change, and here we have one example of a patient whose IVC measured 2.22 centimeters both in atrial fibrillation and sinus rhythm. Now, you may have noticed in these three examples I've chosen to show you, the blood pressure and the heart rate did decrease substantially in each of these cases. And indeed, this was a trend that we saw throughout all our patients, namely that blood pressure, both systolic and diastolic, as well as the heart rate, was significantly lower following cardioversion compared to prior to cardioversion. However, these baseline hemodynamics did not correlate with the IVC measurements, nor did the change in the hemodynamic parameter correlate with the change in IVC dimension that we saw. So in conclusion, the maximum IVC dimension was significantly larger in the presence of atrial fibrillation compared to sinus rhythm in the same patient as measured by handheld ultrasound, and this effect seemed to be independent of hemodynamic changes. IVC collapsibility was also less common in atrial fibrillation compared to sinus rhythm. And as I mentioned, almost 50% of patients were reclassified by guidelines to a lower estimated range of right atrial pressure following cardioversion from atrial fibrillation to sinus rhythm. So how do we interpret these data? Well, one possible interpretation is that atrial fibrillation influences both the size and the dynamics of the IVC and may represent a confounder in the interpretation of ultrasound-derived right atrial pressure estimates. You might postulate that perhaps this is due to a change in venous inflow pattern with loss of atrial relaxation wave in atrial fibrillation, or perhaps there was a change that actually existed in hemodynamics that had an effect that we weren't able to pick up on, or perhaps that there was a direct immediate change in filling pressures following cardioversion to sinus rhythm, in which case you might postulate that simple handheld ultrasound measurements can be used to demonstrate dynamic changes in filling pressures in real time. I mentioned that this is an ongoing study, and in the future we plan to look at these patients that are undergoing cardioversion and try to address the question of how to risk stratify these patients as to their likelihood of going back into atrial fibrillation. We all know that there's a high likelihood of recurrence of atrial fibrillation after cardioversion, even despite antiarrhythmic therapy. There are a number of risk modifiers that have been identified that can help stratify this risk, some of which are modifiable, but additional clinical predictors would be clinically useful. So we'll be looking at the patients that undergo cardioversion and you might postulate that handheld ultrasound measurements of the IVC could be used to predict atrial fibrillation recurrence post-cardioversion, with perhaps the patient with a dilated IVC prior to cardioversion that doesn't change following conversion to sinus rhythm might be someone who is more likely to go back into atrial fibrillation versus a patient with a non-dilated IVC that drops after conversion to sinus rhythm might be someone who doesn't have recurrent atrial fibrillation. And indeed, there is some data to support this postulation from catheter ablation studies, which have shown that left atrial pressure is associated with increased risk of atrial fibrillation recurrence following catheter ablation, and additionally that the change in left atrial pressure following ablation, in other words, following the conversion of atrial fibrillation to sinus rhythm, is also a predictor of risk of atrial fibrillation recurrence. So stay tuned for some additional updates as this data evolves. I'd like to thank the following individuals for their instrumental help in helping this project be successful, and thank you all for your attention this morning.
Very interesting observation.